Welcome to the 2022 annual community briefing for the Hazelwood Health Study. I'm Michael Abramson from Monash University. I'm the principal investigator of the Hazelwood Health Study, and I will introduce you to other investigators and researchers as we proceed. First off, I would like to acknowledge that we are meeting today on the country for which the Brayu Kalun clan of the Gunnar Kurnai people have been custodians for many centuries. We pay our respects to their elders, past and present, and I would also like to pay our respects to any Indigenous people who may be participating today. So our agenda this afternoon is to hear some presentations and updates from the various streams of the Hazelwood Health Study, starting with the early life follow-up stream, the respiratory stream, Hazel Links, which utilises routinely collected health data, community wellbeing stream, and psychological impact stream. And then we'll have some comments on local impacts and community engagement. And I'm really pleased that people from the La Trobe Health Assembly and the Gippsland Primary Health Network and hopefully the Advocate's Office have been able to join us today, and we will conclude with questions and answers. So if you have questions as we go through, please post them in the chat and I can then direct those to the appropriate person at the end. So I think that's about it from me for the moment, and I'd like to hand over to Faye Johnston from the University of Tasmania and Menzies Institute, who's the principal investigator of the early life follow-up stream.
Thanks very much, Michael, and hi everyone. It's lovely to be here again. I lead this particular stream of the Hazelwood Health Study, which is investigating for long-term health impacts of exposure, either for a child in their first 2 years of life or to their mother while they were pregnant with their child. So I'll give you, when I get to results, I'll always do it in two parts, the pregnancy exposure part and the early life infant exposure part. The other thing about the early life follow-up study, it's got two streams within it. One is the stream, the clinical stream, following real life kids and families who kindly donated their time and come for assessments and filled in questionnaires. So we've been able to get very detailed information about their health. But numbers, of course, are smaller for that kind of thing, and it's 7 years now. So numbers do tend to dwindle as people can't always come back year after year for checks. And we have a parallel stream, a data linkage stream called ELF Links, which has all the children in the valley, and we're able to look at hospital and other such data sets, routine data, and learn that way. So we're looking from two ends, at children's health, a detailed end and then a bigger picture population end. Okay, so our recent activities, there's really only one word for our recent activities, and that's data analysis, both for the clinical tests that were last done last year and also for the fully linked data set. And what I wanted to show you here was the ELF stream alone. Apart from what we're learning about health, the Hazelwood Health Study has been fantastic for training new researchers. In ELF, we've had 5 PhD students, 2 public health doctors in training and 2 medical students. And one of our medical students made a fantastic video explaining what it's like to be a participant in the ELF clinical data collections. And she had a lot of fantastic young volunteers happy to be actors and their parents happy for them to be actors. So it gives you a very good flavour of what we've been doing and what the children and families have been contributing.
I went into the doctor's clinic today for a checkup of my heart and lungs. It's part of a study called ELF. I think it's kind of like a big science project for adults. The scientists are checking to see if smoke from the mine fire a few years ago had any effect on kids' heart and breathing system. When we got there, We were asked a lot of questions and Mum had to fill out a form while I played with the toys. The lady explained how the day would go, which was very helpful, and then she measured my height and weight. I had to take my shoes off. Good thing they weren't smelly that day. The first room I went into had a cool machine in the corner called an ultrasound machine. They said they could see my insides with it. It's the same machine they used to look at my baby brother when he was in my mum's tummy. The scientists then stuck on some special dots on my arms and legs and connected them to a machine. This was to look at the electricity flowing through my heart. Someone else put some jelly on a funny plastic thing called a probe and put it on my neck. It was a bit cold and tickled. I wanted to let out all my giggles, but I had to lie down really still. In the second test, they used an inflatable cuff to measure my blood pressure. I could feel it puff up, but it didn't hurt. The best part of checking my heart was watching Peppa Pig on the iPad while they were looking at special blood vessels in my neck. After they checked my heart, I went into another room. This time I had to play a game where I blew into a machine for 6 long seconds. It was a bit tricky, so I didn't get it the first time, but after a couple of tries I got it. After the first test, they put a nose peg on me. I looked really silly. For the second test, I was breathing into a new machine, but all I had to do this time was breathe normally. Sometimes my cheeks wobbled and it felt a bit funny, but this test was so easy. I had to do it a couple of times. I didn't mind because I got lots of stickers each time. In the middle of the test, I was given some medication from the puffer and then I had to wait to do the test all over again. By now, I was an expert. Everyone was really nice. I got to see some cool machines and watch my favorite show. Oh, and I got to take home a special toy. I'm glad I'm one of the special kids that are able to help this important study.
They put some special jelly stuff on my neck, and yeah.
Did it take a long time?
Yeah.
But was it still fun?
Yeah.
Why was it fun?
Because I got to watch PJ Masks.
And they're good results to share. We checked, as you will see, heart and lung and blood vessel markers of development and markers of function. And in our clinics that we did just 3 years after the mine fire, we did find some small associations between mine fire exposure and slightly stiffer lungs and slightly stiffer blood vessels. Very small changes, probably not of direct clinical sort of importance, but the fact that we could measure them did tell us that there was an effect of the smoke. When we came back 7 years later, just last year, and did the same tests on the kids, we didn't find any associations with any of the groups. So what that meant was that whatever we found the first time round, we didn't see the second time round. Could be for a number of reasons. One is that there's been some recovery, whatever the impacts was over the years, kids have grown and regained whatever function that was inhibited at the time. The other reason, though, is numbers got smaller and the kids who choose to participate and families tended to be kids who had lower exposure. So whether this is true across the whole group of kids in the valley or whether it's because we've got small numbers of healthier kids who had lower exposure, we don't know at this point. And that's the purpose partly of doing the data linkage studies, to get information from another source. And it's also the reason we're really keen to get fantastic numbers to our next clinic next year. Last year, of course, there was COVID, there were wild storms, there were lockdowns, and it was really amazing of the team to pull off, and that so many people came despite all those things. Next year's clinics will really be quite pivotal in helping us interpret. Okay, so as I said, when we actually directly did the tests, we didn't find any associations between mine fire smoke exposure and any of the lung function measures or any of the blood vessel measures. When we looked at data, and that, as I said, they were 7 years from the fire. When we looked at the data, this was actually 1 year after the fire, so it's the year following the fire. We did find, for the kids whose mums were pregnant at the time, an increase, a very small increase in emergency department presentations for skin rashes, not including nappy rash, and also prescriptions for oral steroid medication. So that's medication commonly used either for severe asthma or severe croup. So it indicates a link with either infections or lung health. And interestingly, we also see associations in presentations to hospital with background air pollution, even though background air pollution in the region is relatively, low. So just quickly to give you the results of the kids who were infants, they were aged less than 2 at the time of the fire. And again, nothing at the clinics, but when we looked at the data for the year after the fire, we saw associations with emergency department presentations for respiratory conditions, especially infections, and for all infections, and for prescription of antibiotics. And again, we also found links to some of these outcomes with background air pollution. And our future plans, more clinics next year and more data linkage that will enable us to look further beyond a year after the fire, up to 5 or 6 years. The approval system and the data's on the way.
Thanks very much, Faye. And I guess it just highlights the issues about the digital divide. You even face it in a custom-built facility like you have down in the valley for today's community briefing. So at this point, I'd like to hand over to Bridget Borg from the Alfred Hospital, who leads the adult respiratory stream.
Thanks, Michael, and welcome everybody. First up, I'd really like to thank the participants and the Latrobe Valley community for their continued engagement in our study. So in terms of the respiratory stream, what we've been doing over the last 12 months is continued analysis of some of the data from the first round of clinical assessments that were done in 2017 to 2018. Last year, we collected more clinical data as part of round 2, which was interrupted a lot by COVID lockdowns, but we did get it completed sort of mid-November last year, and we've started data analysis there. And recently, Tyler, who's going to speak after me, has started collection for the long-term respiratory study and eating survey. In terms of round 2 data collection, you can see from the numbers here on the screen that in round 1, we had about 346 residents of Morwell participate in the study and 173 from Sale. In round 2, the numbers were a little bit down. Participants who had participated in round 1 were invited to come back for round 2. We had 217 Morwell residents participate in round 2 and 112 from Sale. So it was about 64% of the round 1 total that came and participated in the round 2 data collection. So in round 1, just as a reminder, we found that exposure to increasing levels of mine fire smoke was associated with less stretchy lungs, higher prevalence of COPD like lung function in non-smokers, so more airflow obstruction in non-smokers, and worse asthma control. We haven't finished analysis of the round 2, but preliminary analysis is suggesting that exposure to increasing levels of mine fire smoke may no longer be associated with changes in lung function. So this is similar to the ELF study findings. So it could suggest that there may be some recovery of lung function changes that we saw in round 1, or like the ELF study and phase suggestion. It could also be because we had lower numbers attend the round 2 data collection visits. So these results need some confirmation, and we'll be releasing those a little bit later this year, we hope. So in terms of future plans, we still have to complete analysis of the round 2 questionnaire data, which this time was collected online as opposed to interviewer based at the time of the clinic visit. And we also need to commence planning for round 3 data collection in 2023. So that is just about to get underway. And we're hoping that next year we'll be returning to the Latrobe Valley to recruit and collect some more data with clinical visits so that we can have a look and see whether we have continued improvement, if that's in fact what the round 2 data shows us, or whether there are further changes in lung function in the participants that we've looked at. I'll now hand over to Tyler Lane, who will discuss the long-term respiratory study.
Great, thanks very much, Bridget. So we're going to ask some follow-up questions of people who participated in the adult cohort survey. And what we're interested here is to learn about the longer-term effects of smoke exposure from the mine fire. And our primary objective is to understand, 8 years after the fact, do people who have had more smoke exposure have more respiratory symptoms? An earlier survey, which was about 2016, 2017, the adult survey found a higher prevalence of cough and phlegm, and I think 1 or 2 other outcomes. And we want to see if some of those have been sustained or if others have emerged in the meantime. But this is also an opportunity to take a cohort that was established before other events occurred and see whether these have had an effect as well. And the first of those is more smoke exposure from the Black Summer in 2019 to 2020. What we're wondering is whether this added effect of more smoke has worsened respiratory symptoms. Now, the Black Summer didn't hit Morwell as hard as the Hazelwood mine fire did, but there's still a reason to suspect that the combination of the Black Summer and the Hazelwood mine fire exposure could lead to more respiratory problems. The other big event that has occurred since the initial survey is the COVID-19 pandemic. And what we're interested here is in 2 outcomes. One, whether smoke exposure from the Hazelwood mine fire has increased people's vulnerability to COVID. So not just a greater likelihood of infection, but also severity of that infection. But in addition, we want to see whether exposure to the mine fire and COVID combined is predictive of even higher proportions of respiratory problems. The last thing we'd like to do with this survey is to see whether eating habits can influence respiratory problems among people exposed to smoke exposure, specifically whether it offers any protection. There is some emerging evidence that diets that are higher in antioxidants may offer protection. Well, maybe not protection, but they reduce lung function decline that happens to all of us as we get older. So what we are wondering is, do people who have better diets have some sort of defense against respiratory problems that emerge from the smoke exposure? So the survey that is addressing these questions has been in the field since mid-August. We're hoping to wrap up by the end of this month, maybe a little bit later as we follow up with some more specific questions. And we've interviewed approximately 600 people so far. As well as this survey, we have done a bit of other work on a review of evidence on air pollution and COVID-19, and more specific than air pollution, fine particulate matter. And what we're finding is that the fine particulate matter specifically seems to be linked to higher risk of COVID infection, at least when measured concurrently. We don't have evidence from previous exposures, years past. So this will be addressing a new question. There is some weaker evidence, but still somewhat convincing that this small particulate matter, fine particulate matter, increases the severity of COVID infection and also the likelihood of mortality.
Thanks, Tyler. And can I just encourage people watching online to post questions in the Q&A, which we'll deal with at the end. The next stream is the Hazelink stream, which is utilising routinely collected data, and you can see the sources of the data acknowledged there. And I'll invite Yu-Ming Guo from Monash, who's the lead investigator, to present the findings to you.
Thank you, Michael. Hi, everyone. Nice to meet you here. I will introduce the study for the Hazelink stream. For the Hazelinks, we mainly have two parts. The first part is to use the general routine data collection for the deaths, emergency department visits, hospitalizations, or some data. And another part that is the linkage for the alert survey. For example, for the participants of the alert survey, we will link their data to the death registry, cancer registry, or cardiovascular disease registry. We want to follow up them to look at the long-term effect. We want to update the recent activities because most part of this work has been done in the last 5 years. So, but we are still working for some other data collection and to perform some further data analysis. Currently, we are doing a second round data extractions to request the identified data, for example, ambulance data, hospital data, and the cancer data. For the ambulance data, we will request the data between 2009 and 2021. We need to get another 6 years data. For the hospital data, hospitalization data, we will get the data between 2009 and 2022, also approximate 6 years extension. And for the cancer data, we need to get the data between 2009 and 2020, about 5 years extension. And then when we get this data, we will do some spatial analysis, spatial temporal analysis to understand the long-term effect of coal fire smoke and this data health outcomes. Here is some update for our recent findings, which is using the identified data linkage, that is linking the data of alert survey and some health outcomes like emergency department visit. For example, for this one, we performed a study to look at the long-term exposure, the long-term effect for the 6-week exposure to coal mine fire-related PM5 and the emergency department presentations in the following years. For this study, we found the 6-week exposure to coal mine fire-related PM5 was related to the increased risk of respiratory-related emergency department presentations over the following 5 years after the coal mine fire. And also, there was an increased risk for cardiovascular-related emergency department visit in the first 2.5 years after the coal mine fire. But this effect subsided after 2.5 years. Here is the field plans for the Hazelinks. We will do a second round data linkage for the alert survey. We will request more data for ambulance attendance, cancer data, and mortality data. Particularly for the cancer data and mortality data, because our previous studies have not found the relationship between coal mine fire-related PM5 and the cancer risk and also the mortality risk. That might be the one reason that is a very short follow up. So we needed to get longer data, more data for a longer follow up. So if we update the data in the future, we can give I will get more sample size for the mortality data and the cancer data. Hopefully, we can get some new findings. Okay, I think this is our update for the headlinks. Thank you very much.
Thanks, Yuming. Can I invite participants to put questions in the Q&A, and we'll discuss those at the end. It's my pleasure to introduce Sue Yell, who's from Federation University and leads the Community Wellbeing stream, and I guess Sue will also introduce her colleagues to you.
Thanks, Michael. And hi, everyone. Good to be here, good to give you an update. Yeah, I lead the Community Wellbeing stream. So we are based out of Federation University, but we have colleagues at multiple sites now. So Matthew, whom you all know, and also Michelle Duffy, formerly of the Churchill campus at here in Gippsland, and also Damien Morgan, also formerly based in Churchill, both moved on to other positions but continue to be keenly involved in the community wellbeing stream. And also our RA, who is Dr. Larissa Walker, who is also locally based, trained at Federation University, and a Morwell girl, I might add. So the community wellbeing stream has been tracking the community's wellbeing and recovery since the mine fire in 2014, but obviously a fair bit has happened since then. So we've broadened the scope of our work to look at the impact of other major events like the closure of Hazelwood, obviously the Black Summer bushfires, the COVID-19 pandemic, and there have been other things too that have been significant, and some of them have had either positive or negative impacts. So we want to take all that into account in looking at community wellbeing. We're also supporting the work of the psychological impact stream, and we're looking, teaming with them to look at the relation between community wellbeing on that kind of collective level and individual wellbeing on that more personal level. The work that we're doing on community wellbeing includes both a subjective and an objective perspective. So we're interested in how the community perceives itself, but also about what statistics say about the community's wellbeing, looking at objective data. So that might be things like stats on access to health services, employment figures, crime rates, rates of voluntary work. To understand how this community perceives itself from that subjective angle, we've been conducting interviews. So about a year and a half ago, we did interviews with 30 community members and key stakeholders. And we're very grateful to those people for their time. We're also following local media and social media to understand the issues of concern that are being raised there, but also the things that this community is proud of, positive aspects as well. And we're gathering data from the mental health and wellbeing follow-up survey that was conducted by the Psych stream back in early 2022. And in that survey, there were questions about subjective aspects of community wellbeing. So how people think community wellbeing is going. And we're currently analysing the information from that survey. To understand the community wellbeing from a more objective perspective, the stream's been working on developing a tool that we call a community wellbeing barometer. And this aims to measure community wellbeing using objective indicators taken from publicly available data sources. So surveys and data that's already collected by other organisations, so including things like the census and various Vic Health surveys. We then compile this data into graphs that show changes in community wellbeing over time. So this is a graphic representing the 5 elements of the community wellbeing barometer as we've developed it so far. So we talked to our interviewees about what they thought were the key aspects of community wellbeing, what are the things that really impact on community wellbeing, and came up with these 5 domains. So services, infrastructure, social connections, the environment, the economy, and health. And then within each of those domains, we've broken them down into a number of themes. And then the final step was to identify objective indicators. As I mentioned, these bits of data that can be collected from existing surveys and that can be measured. So we're using those to indicate changes over time in each of the themes. So there might be an improvement or there might be a decrease in levels of community wellbeing against each measure. And when we put all of this information together, the aim is to map communities' resilience and wellbeing across time and try and correlate that with significant major events. So our next step is to take the barometer and the information we have so far back to our key stakeholders to test its accuracy and validity, to kind of check with them, well, you know, given what they know, they're more, you know, close knowledge of the community, to see if that sort of tallies with how they see this community travelling. And ultimately, once we're satisfied with how the barometer works, we aim to share it as a tool with any other interested organisations who think they could use it for their own purposes in how community wellbeing is travelling. It's particularly designed for this community in Latrobe, but it could be applied in other communities as well. Early next year, we plan to conduct another round of interviews with our stakeholders and community members to go back to them and ask them if their perceptions of community wellbeing have changed at all since we last interviewed them in 2021. And then we'll put all of these data sources together, so what the barometer is telling us, what our interviewees are telling us, what we're seeing reflected in the media and social media data, and also the survey data, to give us a more complete picture of community wellbeing, including what makes this community resilient, as well as its areas of vulnerability. And finally, we'll continue to look at impacts on older people and what we can learn from our elders. Age continues to be one of the key factors considered in the analyses arising from the other stream areas. So that's it from our stream. And I'll hand back to Michael to introduce the next speaker.
Thanks, Sue. The next speaker probably needs no introduction. Matthew Carroll from the School of Rural Health at Monash leads the stream investigating psychological impact. So I'll hand back to Matthew for a live presentation.
Thank you, Michael. So this year's actually been a fairly intense year for the psychological impact stream because there's been a lot of data collection. We've had 2 surveys running almost at the same time. We started the year, about 3 months ago, we started a collaboration with the Early Life Follow-Up stream, where we actually sent a survey out to all of the participating families. And we're wanting to look at the relationship between parent and child mental health and where that sits in terms of level of exposure to the mine fire. So we were quite pleased. We got over half the cohort did the survey for us. And that's some people who had their last interaction with health was back in about 2016. So they've been invited to various health parties and so on, but may not have actively been involved in research for 5 or 6 years. So we were quite pleased with the result of that. We stopped that survey about a month ago. We're literally just starting to look at the data now. So we'll be reporting on the findings of that next year. So that should be quite exciting. And we're right now actually conducting the next round of our mental health and wellbeing follow-up survey. So we did the original adult survey back in 2016, 2017. That was a big survey with 4,000 participants. We then followed up that survey in 2019, 2020, just on the Morwell cohort. And that we'll be reporting on that in a sec. But we're now doing a second follow-up of that adult survey. So that really gives us 3 points of time to follow people's well-being. Interestingly, the last one happened to be during the Black Summer fires. So useful time, but perhaps not the best time to ask people how they're responding to Hazelwood. This survey is happening now and will be completed before the end of the year, so that we get people, when there's no other smoke events, there might be flood events, but no other smoke events, prompting their responses. So again, we'll be reporting on that next year. So these 2 batches of findings, and I'll give you a little bit more details in the subsequent slides, are actually from that 2019-2020 survey. And in this case, we've done quite a number of papers from that. These are the ones in the last year, and they're relating to patterns of psychological distress that are still apparent over time, and also the relationship between reporting of physical symptoms and psychological distress. So this graph basically gives you an image of the different types of response patterns that people might have. So you can have someone, and this is across the different time points. So the orangey bar is the mine fire. The first grey bar is our first survey in 2016-2017. And the next bar is the follow-up survey. And in a year's time, we'll have another bar for the next survey. And basically, you've got people's patterns of distress. So people who didn't report distress at the first survey and still weren't reporting distress at the second survey, which is where we want the majority of the community, they're the resilient trajectory. And as you can see, we've got almost 80% of the community in that trajectory. Then there are some people who had delayed onset, where they actually didn't report it in the first instance, but then reported it in the second instance. And in truth, that's possibly due to the effect of the Black Summer fires, which is why we think these results are interesting. There are people who are in recovery who may have reported it in the first instance, but then by the time of the second survey, it's dropped off. And then there are people who are reporting it at both time points. They're the ones we're most concerned about because they've got ongoing and persistent distress. And so what the analysis is doing, and I won't go into a lot of detail here, but it's trying to identify the different risk factors for those groups, and in particular for those who show chronic distress or delayed onset distress. We can see that they're more likely to have less social support or be more lonely. They may have reported prior traumas in their lifetime, so they're major significant traumas at any point in their life, or recent stressful events like conducting a community briefing in the last year, physical health or mental health diagnoses and so on. So we can identify some of the risk factors which you think are going to be clinically useful so that when events like this happen, people can look for those sorts of factors and try and find the groups to support. Now, I don't expect you to be able to read this slide. The main point here, again, this is using the same data and looking at levels of distress, and in fact, 2 different sorts of distress. The blue bars are distress associated with the mine fire, and this is 6 years on from the mine fire. People are still reporting distress that's associated with that event in 2014. The green bars are just in the last month, have you been experiencing distress? That's the Kessler 10-item distress level. And what this is actually tagged against is reporting of 15 general physical symptoms. So that's various pain, so pain in limbs, back pain, headaches and so on, diarrhea, shortness of breath, stomach pain and so on. And the take-home message from this slide is that almost every single one of those green and blue bars is on the other side of the dashed line. So what that means is there's a significant relationship between both forms of distress and each of these symptoms, with the exception of mental problems, which would a smaller set, as you suggest, and it's because there's overlap between the surveys because that's actually tagged in there. So what that's telling us is that there is a clear relationship between people turning up with these obscure pains that they don't have a particular reason for, and potentially post-traumatic stress, because these are measures of stress following the mine fire. And so what that's saying is that when you're dealing with a community that is responding to an event, and you turn up to a GP or whatever, and someone says, look, I've had this back pain, which was me in the last week, then why do you want to obviously look at physical causes and isolate those? It's also worth thinking, wait a minute, this is post an event. I really should also wonder whether this is evidence of post-traumatic stress, and consider screening for that as well. So we don't know what the answer is, but we know that clinically it's worthwhile looking for other reasons, not just the reason the person's turned up, because it could be it's to do with distress. So our future plans, as Sue mentioned, we're continuing to work with the community wellbeing stream to look at that link between individual and community wellbeing. And the survey that's running now has actually got a measure of community wellbeing. The survey that ran 2 years ago actually said, how do you feel about your community and how has it changed since the mine fire? So we're trying to track that, but we're also tagging it to things like individual distress and so on. So we'll be able to understand whether community wellbeing is the sum of all the individual wellbeings or whether there's something else going on there. And as I say, we're about to start work on the ELF stream data that we've collected. And so we'll be talking about that next year, and the adult survey data that we're collecting right now. And there'll actually be another round of the ELF data in probably 2024 as well. So more data collection to come.
Yes, so you don't have to go very far, Matthew. I'll invite you to provide some local perspectives in your role as co-principal investigator, Gippsland.
Thank you. And before I move on to the next slide, just really wanted to, as I think Faye said and Bridget said, we really do want to thank everybody who's involved in the Hazelwood study, the participants who've done surveys over time, who've done clinical assessments. That's hard work, turning up for an hour and a half of clinical assessments. As Faye said, regardless of flood and fire and everything else, it was an interesting time when we're doing the last round of assessments. So really do appreciate the hard work that people have done to come and help us, and do appreciate the work of the team and all the supporters that we've got, because there's a lot of stuff coming out of the study, but it's only coming out of the study because of the commitment that people have made to it. So as you can see, we're continuing to report on short-term impacts. So that's things like you need to talk about the increased emergency presentations for heart-related conditions in the 2.5 years after the mine fire. So we're still releasing some of that early stuff, but we're increasingly focusing now on long-term impacts, such as the work I just presented on ongoing distress and its association with physical symptoms, and the work that Faye was presenting and so on. They're starting to get some reassuring findings. They're still to be confirmed, but we're getting a sense from some of the findings from the adult respiratory stream and from the ELF clinical assessments, and some of the things we saw in the clinical assessments in 2017 may not be showing up again in the last round of assessments, and that'll then get confirmed in the next round. But that's actually what we want to see. We want to see that some of those effects wash out over time, but we don't know, we can't confirm that yet. So let's see how we go in the next round. And we're really keen to try and provide more information that's of general relevance to the community. And I think Tyler's survey, the long-term respiratory survey, is particularly interesting because it's actually asking new questions. They're not really Hazelwood questions, though Hazelwood's part of the analysis plan, but it's more about what's the relationship between Black Summer and COVID-19 and eating patterns and respiratory health. So there's a potential there to get really interesting findings of very much relevance to the community going forward. So I think that'll be quite good. And we already know, as we mentioned last year, there's a close intersection between the work we're doing and the work that our friends at the Assembly are doing in terms of the collection of food data, because our data from the first cardiovascular round informed the My Health swaps and other activities that the La Trobe guys are doing now, and now we're collecting more health data as AU, and so we'll bring our pieces of the puzzle together with your pieces of the puzzle to try and to really shed light on healthy eating patterns in the region. So where next? So for those that don't remember, the Hazelwood study was funded as a 10-year program of work by the department, but there was recognition at that time that some of the questions will not be answered in 10 years, particularly things like cancers will not be apparent in 10 years, and that there was a need for further work. So we're now thinking in that space as to where to next. Our first priority is to make sure that when we get to the end of this 10 years, that everything we've done actually is made use of. So we're trying to get our research findings out to all the potential stakeholders. We've got some examples of research summaries over in the corner there. They're all up on our website. We'll be looking at sending them out to community locations, but we're really keen to talk to the community about what we found, and not just in this you come to us things, but we go to your groups and come out and say, well, this is what we've done over the last 10 years. What does it mean for you? Where can we take it next? But also to talk about where we could go further. So as I say, we're really keen to see the study continue. We're working on a possible proposal for future funding of the study to go perhaps beyond cancers, but to look at how the ELF cohort grow up into young adulthood, So continue all the wonderful work of the Hazelwood stream in terms of data extracts and so on, to understand the health of this community going forward. So there'll be a lot of conversations that are going to be started and continued over the next 2 years about where to next, what to do. If you've got comments or suggestions, raise them in the next couple of minutes, but also you can always email us at any point to our contact email address. If you want us to come out and speak to you, send us suggestions, and that's whether that's to a stakeholder group, to a community group, to a health sector, to whatever. Our job over the next 2 years is to come out and connect and show what we've got and where it links into what you're doing and trying to make sense of things. So I think that's it. Probably back to you, Michael.
So thanks very much, Matthew, and I'd like to thank all the presenters for sticking to time. We've got plenty of time for questions and answers. So I'll invite our Senior Project Manager, Jill Blackman, to field the questions. And just to note, there's questions both in the chat and the Q&A to be answered. So over to you, Jill.
Thanks, Michael. Yes, we do have a few questions that have come through. We really appreciate those. So the first question I have is for Faye, if she's still with us. And the question is whether the small associations that were found at the time of the first round of clinical testing, those associations between mine fire exposure and some stiffness in the lungs and blood vessels, whether it's possible that those associations found at round 1 but not at round 2 were due to chance.
Thanks, Jill. Yes, I'm still here. And that's a very good question. We're dealing with small numbers in both clinics, but we had greater numbers in the first round. And what our results there were statistically significant, and that means, P equals less than 0.5. So there's a 5% or lower probability that it was chance findings, although we got them across different streams, and perhaps a 95% chance that it wasn't due to chance. That's just going on the statistics, but there's other reasons as well. So if it is an association that's not due to chance, could it be true? Could it be causal, or could it be due to other factors biasing or confounding that we couldn't measure? So as with every epidemiological study, you need to think very hard about all these things: chance, bias, confounding. And if you've got enough participants for negative, when you don't get an association, have you actually got enough participants to do the study and to test? So I can't give you a firm answer, but yes, chance is one of the possible explanations, as it always is. I think it's more likely we were underpowered in the second round than it was a chance finding in the first round. But all of these explanations are possible, and the third round will actually be quite crucial, particularly if without COVID, if we are able to have more people attend, that will be quite crucial in helping us tease this out.
Thanks, Faye. So the second question actually is directly related to Faye's comments there about potentially being underpowered in the second round of clinical testing. We noticed a reduction in participation numbers in both the ELF's second round of clinical testing, but also in the adult respiratory stream. So there's two parts to this question. One is whether that reduction in participation rate could be related to community anxiety in relation to things like the pandemic, but also whether it could be related to increasing trust in government, and therefore people are less concerned about the Hazelwood Health Study. I'm actually going to have a quick go in response to the first part of that question. There's absolutely no doubt that the COVID pandemic adversely impacted our participation rates for both of our clinics. Not only did a number of lockdowns occur during our data collection period, I think there was also a flood in there that closed down the early life follow-up clinic for a while as well. I personally know people who still don't go out for a takeaway cup of coffee. So there's no doubt in my mind that many people who were sent invitations to participate in our clinics in this second time round were not willing to go out to a respiratory clinic, particularly a respiratory clinic that was also doing COVID testing. So there's no question that the COVID pandemic adversely impacted on our recruitment rates, and we're hoping that in round 3 we can actually retrieve some of those people that we lost in round 2. I think the other thing, it's not the best word for it, that occurred with the early life follow-up stream is that many of the children are no longer preschool aged and they're primary school aged as well. And so we have parents who are less willing to bring their children out of school potentially. We were able to pick up numbers during the school holidays, but we expect that had an impact as well. In regard to the question about whether there is an improvement in trust in government, I wondered whether Sue might have some comments about that.
Thanks, Jill. Yeah, I guess we can't probably definitively answer that at this point, but we are definitely looking at trust as a factor, both through what people tell us in interviews around community wellbeing and also through the data we're collecting from the barometer. So one element of the barometer, within the domain of social connections, obviously trust's a big part of that. And we are looking at data that talks about the data that we're collecting is around a measure that reflects trust, agreeing that most people can be trusted, I think is the specific measure that we're going to incorporate, or that we are incorporating to the barometer. So we will have some data that will show over time whether that's fluctuating up, down, staying around that same level. But we're not quite ready to kind of say for sure which direction that's travelling. And also when we repeat our interviews early next year, no doubt we'll have a point of comparison. People said about community wellbeing and trust.
I can add a little bit to that, Sue, in the surveys that we've been. The community wellbeing measure includes a trust question.
Yes.
So we will be getting the answer to that right now. I can also say that anecdotally, we've certainly had people who've responded to our survey saying, no, I don't want to do it because I don't trust you, because you're part of the government and because the government's doing all these things. So, it goes both ways, unfortunately.
So we are close to running out of time. However, we do have a couple of other questions. One of them I thought perhaps we'd direct to Michael, and that's a question about whether the associations that we have observed between the smoke exposure and health outcomes, in relation to those, whether we have evidence of a dose-response relationship. And perhaps, Michael, you could give the lay audience a quick summary of what that means.
Yeah, thanks, Jill, and thanks for the question, Tim. So the concept behind a dose-response relationship is the greater the exposure, the greater the effect. So yes, we have found evidence of this, particularly in the respiratory stream. There was a very clear dose-response relationship between exposure to PM2.5 and the prevalence of chronic cough, which made good sense because cough is one of the mechanisms that the lung uses to try and clear inhaled particles. Most of the analyses that Bridget referred to from the first round of respiratory testing also attempted to fit a linear function of the PM2.5 exposure. So there was a relationship with some measures of lung function, such as features of chronic obstructive pulmonary disease and also stiffness of the lung on the forced oscillation testing. The other general comment that I would add is that increasingly the literature in the area of air pollution research is finding that there is no threshold. So we have this so-called National Environment Protection Measure, 24-hour average PM2.5 concentration, 25 micrograms per cubic metre. We cannot assume that that is in fact a safe level. Research is increasingly showing health effects at lower and lower concentrations. And I'm aware that there are similar findings from other streams of this project, such as the psychological impact stream. And I could go on, Jill, but perhaps I should give you a chance to ask some of the other questions.
Thanks, Michael. I think we have time for one more. And that's an interesting question about the K10 instrument, which is an instrument that that measures psychological distress that we used in our psychological health follow-up surveys. And the question is how the psychological distress that we see in our adult survey cohort compares with other surveys such as national surveys or Victorian-wide surveys in terms of the levels of psychological distress in our survey compared with the Australian population or the Victorian population. So Matthew, you might have some ideas about that. Otherwise, I think Caroline might be able to address that for us.
In the original adult survey, Jill, I know we had a look at the K10 because the K10 is a standard measure that's used in multiple surveys, which is why we chose it. And we found that it was somewhat elevated compared to the regional and national averages. That the level for Morwell and in that original analysis was definitely higher than that of Sale, but the majority of people were still in the low level stress band. There were, I think, about 25% of the sample in that original survey that were actually showing higher than average levels, and so that was somewhat concerning. We can't yet report on the most recent data that I've got, which is the ELF follow-up survey, but there is starting to see something of a signal coming through there, but that might be a COVID or a signal more so than a Hazelwood signal, given we don't have the prior time one measure for the ELF family because they weren't part of the original adult survey. So yeah, there's some evidence that we're a bit higher, and there was evidence in the original analysis that was clearly related to level of smoke exposure. The more smoke that people had, the higher general distress that they were reporting way back in 2017, and that relationship, it didn't continue in the follow-up 2019-2020 analysis. We didn't see a relationship between smoke and K10 in that second analysis. We did see it in the impact of event measure of distress, which is particularly a post-traumatic distress measure. In that instance was tagged against mine fire. So people were being said, now thinking about the mine fire, are you still having trouble sleeping? Are you still having flashbacks and so on?
Thanks, Matthew. I wonder, given that you have some people in the room with you, whether we take the opportunity, even though we're just a couple of minutes over, to take any questions from the room.
We did lose a few minutes at the beginning as well, so I'm sure people...
That's right.
Does anybody have a particular question they want to ask?
Yes, I did have.
People here.
I wondered how you tease out the ongoing lifestyle impacts and trauma that, you know, is experienced generally from what you're assuming might be related to the mine fire. We live in a very active community that has a lot going on apart from people's normal lifestyles and dramas that happen. How can you separate all of that?
It's challenging over time. So in the very first adult survey, we collected a lot of information about individual risk factors. And so we've got their people's health background, their smoking, other lifestyle factors and so on. Different surveys have access to different data. So my surveys that I'm doing, because we're focusing on psychological wellbeing, we're also asking questions about recent life events, so things that have happened in the last 12 months. We've got life history of prior traumatic exposures and so on. So there's bits and pieces that we can actually control for in the analysis, but it's really hard to have a completely comprehensive survey asking everything to be able to control for it perfectly. So we can do some, but not all of what you're looking for. And it gets harder the further we get away from the event.
I was just going to very briefly add to that question that from a broad community wellbeing perspective, I think our barometer tool will show a little bit of that in terms of, you know, does community wellbeing drop around the time of a signal just after a significant event. So it won't show that on an individual, you know, person by person level, but I think it'll provide a bit of broad context on that.
Jane, do you want to ask your question?
Oh, thanks, Matthew. I was just going to say that I think it's a really important question that was asked, and it's really relevant in the context that we're a transitioning community in Latrobe, and we know that there are lots of different things, as Lorraine mentioned, that's affecting our health and wellbeing. And I think there's good opportunity to use what comes from the wellbeing barometer, as well as the long-term post-traumatic results, to build that into the plan for Latrobe into the future, so we can actually prevent any other detrimental effects of a transitioning community.
And I think that's one of the arguments for the extension of the study, to be able to look at a community in transition. I think that this community is a particularly interesting community to follow over time, with all of the stuff that's happening in terms of the transition away from coal and stuff.
Okay, we've gone a little bit over time, but I feel that we've had a good discussion of many of the issues, and we've had the opportunity to update you on the findings. So in closing, I'd just like to thank all the participants, all the panelists, and particularly David and the team that have enabled us to give this presentation in this hybrid mode. And we will endeavour to post selected recordings on our website, though some people who have missed part of the session or weren't able to join us today can view it. So thank you very much, and we'll stay in contact. All the best.